Hey, welcome and thank you for being here. My name is Steve Erickson, and I'm excited to share our work on our disability-focused interprofessional education course here at the University of Michigan. I'm joined by my colleagues Laura Smith, Jillian Woodworth, and Jeanne Andreoli. Our team consists of 3 different health profession units spanning 2 of the 3 U of M campuses, as well as the consultant from CRLT. Our team is representative of the rich opportunity that we have here at Michigan to collaborate as one university in interprofessional space. We designed this experience, this course, to address a critical need, preparing health professional students to better understand and partner with people with disabilities. The course is grounded in the social model of disability and intentionally aligned with the IPEC competencies. Community participatory work was also used working with the Disability Network of Washtenaw, Monroe, and Livingston to help design a course and continue to update it. Our goal is to create an interprofessional healthcare workforce that can deliver person-centered, equitable care and reduce health disparities. And in today's presentation, we will walk you through course design and outcomes and then share strategies, lessons learned, and future directions. Next slide. So 1 in 4 Americans lives with a disability, yet people with disabilities face increased risks for poor health outcomes, limited access to care, and lower engagement in healthy behaviors. Persons with disabilities are 2 to 3 times more likely to have comorbidities such as diabetes and heart disease than those without disabilities, often resulting in complex healthcare needs that require medical attention from many multiple healthcare disciplines. One contributing factor to these health disparities is insufficient training, experience, and knowledge of working with healthcare professionals. Overarching goals of interprofessional education and practice: improve patient outcomes, improve patient experience, have increased health equity, lower cost of care, and improve provider experiences. Next slide.
Sorry.
There we go. So our course, we look at it this way. It initially started with a pharmacy-centric course, and then I met our Jillian and Laura, and then we added Jeanne. But we incorporated pharmacy, occupational therapy, and physical therapy students together, along with in the center is our client. The client is the educator and the teacher of our students. This has led to understanding of the lived experiences of our clients, of our individuals, folks with intellectual and developmental disability, those with physical disabilities, and those with sensory disabilities. Oh, I lost my... All right, the course structure. The course is, our experience is embedded within each of our 3 professional programs: pharmacy, occupational, and physical therapy. We have our own courses, but then within our courses, we've embedded this 6-week experience for our students. Students are assigned to a disciplined, balanced team of 7 to 9 people. Each team meets with 3 different community partners living with a physical, an intellectual, and a sensory disability. So 3 different individuals during the semester. And most often this occurred over Zoom. After each client meeting, the interprofessional student team debriefed by sharing their reflections and submitting a team reflection. And then after that, students submitted individual reflections for each disability module. For these client sessions, students completed didactic learning on the IPEC competencies, the social determinants of health, and the social model of disability framework, along with team building and communication skills practices. Okay. Next slide.
I'm going to turn it over to Jill.
Yeah, thanks, Steve. And in our evaluation, we used a mixed methods approach, combining both quantitative and qualitative data. Quantitatively, students completed pre and post surveys that included attitudes toward disabled person scale, the interprofessional socialization and valuing scale, and measures assessing understanding of social detriments of health, as well as the social model of disability, as well as confidence interacting with people with disabilities, knowledge of our IPEC competencies, and confidence working on interprofessional teams. Qualitatively, we analyzed disability-related word exercises, which Laura Smith will go over, individual reflections, team debriefs after client meetings, and client feedback to capture deeper insights into attitude and skill changes. Next slide. This slide shows the aggregated student demographics of the past 3 years we've been running this course. Most participants come from our 3 professional programs, OT being the newest, so naturally it has smaller numbers of students represented here. We also have a small but meaningful percentage of students who self-identify as a person with a disability. And across cohorts, we've seen roughly equal split between students who have prior experience working or supporting individuals with disabilities and those who are newer to this population. The ATDP, just to explain a little bit about what it is, it's a 20 item, it's 20 items on a Likert type scale that is scored by having participants indicate their level of agreement from a +3, which is agree very much, to a -3, which is disagree very much. Higher total scores indicate higher belief in similarities between people with and without disability. And this scale has high reliability. It displays content and construct validity. And we showed significant gains using paired t-tests using SPS for this. To examine whether students' prior experience providing support with PWDs influenced their ATDP scores and self-reported confidence, data was disaggregated. Both groups of students, those with and without prior experiences working with persons with disabilities, showed significant gains in their self-reported confidence in all 3 categories, as well as in their ATDP scores. But what was very interesting with these students without prior experience providing support with PWDs reported significantly lower confidence levels in all 3 categories compared to students with prior experience prior to the interprofessional team experience. But the mean levels of confidence for both groups of students were similar after the interprofessional team experience. Differences were not significant as indicated by a t-test for independent samples. And likewise, significant gains in students' self-reported confidence with interacting, interviewing, and working with PWDs in future healthcare capacities after the interprofessional team experiences were observed. And overall, students demonstrated a clear and significant increase in their understanding of how social detriments of health shape the healthcare experiences of people with disabilities. They also showed a much deeper appreciation for the social model of disability, recognizing that it's not just about the individual's condition, but the environment, the systems, the attitudes that impact participation and quality of care. And to us, it was a powerful reminder of how education can shift perspectives and truly transform future practice for our students. And I'll turn it over to Laura.
Students completed a disability word association activity, which was adopted from Bryan et al. 2005. Here, the students were prompted to submit 2 or 3 words that would come to mind when they read the word disability. The word clouds depicted here visualize that change in word frequencies before and after their IP experience. So the team experience, you can see that there was an increase in frequency of words associated with the social model of disability and positive attributes of people with disability. Very, very clearly there, right? And then you can see the decrease in frequency of words associated with the medical model of disability and the negative attributes of PWD. Next slide. So here we can highlight a significant difference shown with our ISVS socialization scale. This tool looks at individuals and professional settings to see if they are developing social skills and attitudes. And you can see here that we did have a significant difference. And this, again, can be applied to families, patients, and other team members. Jeannie?
Okay, so something that we decided in 2025, our last cohort, was to move from our traditional pre and post analysis that Jill and Laura have been talking about to using what is known as a retrospective pre-post evaluation for their confidence and understanding. And so with this type of a survey design, both the before and the after information are collected at the same time, instead of collecting the data at the begin and the end of this team experience. And so this retrospective approach only collects the data at the end. And it asks participants to self-assess what they know from those two viewpoints. And the reason why we moved to this sort of survey format is that the research has shown that there's some flaws in a traditional pre-post where it's hard for students to know what they don't know in that pre-test. And this is known as shift bias, that participants will use a different frame of understanding in those pre and post periods. And so the retrospective pre-post does address that shift bias. What you can see in this slide that we had significant gains in student understanding and confidence with collaborating on an interprofessional team and understanding the social determinants of health. And it is very similar to the significant gains we got in the retrospective pre-post. The only difference is that in using the retrospective pre-post, those pre-means are significantly lower than what they were in the post. What we also did was did some qualitative analysis of the student individual reflections, and we don't have time to go over all of them. But one of the shifts that I want to talk about is the first one, where we looked at their awareness, a deeper awareness of the social model of disability and the social determinants of health. And we noticed that there was this move from a very conceptual framework to these essential lenses that will drive their ethical and systemic clinical action. And here are some representative quotes here, where the social model helped me to reframe my thinking from what a person cannot do to how external barriers restrict their participation. We also want to share one other thing related to the interprofessional collaboration. And what we noticed is there was a strong shift from the move from division of labor, which is often found in student teams, to where there is a noticeable difference in the parallel contributions to a holistic care. And here is an example of two of such quotes. I'll read the first one. We are each experts in our respective fields, and it's up to us to educate one another, bridging the knowledge gaps and providing different perspectives on how to approach treatment. So all in all, this qualitative analysis that we've done between the word clouds and these reflections substantiate what was shared with our survey instruments, but it gives us a deeper understanding of what the students are learning with that. I do want to turn it over back to Steve to talk about the lessons learned in our future directions.
Great, thank you, team. Well, to summarize here, what worked well in this model was embedding IPEC competencies in both the didactic and experiential components of our courses, centering on the lived experiences of people with disabilities, and creating a space for interprofessional teamwork and problem solving. We also learned some important lessons: the value of intentional team building before our client sessions, the need for flexibility in balancing schedules and team composition, and the importance of strong community partnerships, because our clients are truly the co-educators in our process. All these efforts have been successful on a small scale. We want to grow this. The need for continued commitment, strategic planning, and infrastructure building is crucial to advance the health outcomes of persons with disabilities. So looking ahead, we hope to expand participation in additional disciplines and other institutions and strengthen our assessments to capture the growth of both disability cultural awareness and interprofessional collaboration. Interprofessional education grounded in the lived experiences of people with disabilities helps shape healthcare workforce that understands the collaboration, communication, and cultural awareness. And when students learn with people with disabilities and with each other, they leave better equipped to reduce disparities and improve health outcomes. Thank you from our team, and we look forward to any questions.